We are pleased to co-moderate with my friend Ilan Leibovich this session on the view of the future. It's okay like this? The view of the future. So everyone will tell what he thinks the future is. And in 10 years, Kobe will organize another meeting and see who was right and who said a lot of, I would say, wishful nonsense. So the first one that we have the pleasure to listen to is our friend David Crawford. And please, David, take the floor. And Professor Crawford is going to discuss with us the way to reconsider targeting prostate biopsy in the future. Please.
All right. Good afternoon. What a powerful speaker, and great to be able to follow this. I've been charged with talking about the future being targeted therapy. And so I'd like to break this down into 3 parts: who to screen, how to target, and how to treat. So it was mentioned the other day that the British Journal of Urology each year gives out awards for best clinical paper. This is one we got a couple of years ago, and this deals with about 10,000 men, and you can see it right here, the Bob Crane Prize, 10,000 men. And what we did is we looked at a trigger zone for PSA, for relative risk for prostate cancer, and also for other urological conditions, i.e. BPH. And what we came up with in this publication was a PSA at 1.5 to 4, a diagnostic challenge in a danger zone. And in fact, if you look at the relative risk of prostate cancer developing over 4 years, with a PSA of less than 1.5 compared to 1.5 to 4, it is almost 15-fold difference. And in African Americans, it's even more significant. So our thought was a PSA at 1.5 is a trigger for further investigation. We heard yesterday about a PSA cutoff of 10 and so forth and so on. It's also a relative risk for BPH and progression. This is one of our articles from the MTOPS trial showing a very nice linear relationship between prostate volume and PSA. And we know prostate volume is also a surrogate for obstructive symptoms. What we did, and we submitted this to the AUA, is we looked at about 8,000 men who came in for our screening, and we looked at if we applied these rules, what percentage of men would have a PSA above 1.5 versus less than 1.5, and we actually found out that only about 30% who came in would have a PSA at that level. So what does that mean? So I think that in the future, what we're going to see is PSA should be treated like other lab tests: lipids, weight, blood pressure. It's a reflex test that's ordered on men. And then everybody talks about informed decision. The informed decision would be in those men that have an abnormality. 70% of men would require no discussion. And I think that really reduces the pressure and things like that. And we also associate this with men's health, a broader issue. So we go down and we have this little algorithm that Neil Shore and I put together about PSA 1.5 coming down and conducting a biopsy. And we've heard a lot about some of these molecular markers and how they're going to help. I also think in the future, once that's done, we're going to see other things done like pro-PSA, FI. We're going to see things, a very nice relationship that, as you well know, this came out with positive biopsies. PCA3, we heard a lot about this. Temper-Zerg fusion with PCA3. So I think we're going to go down that path for diagnosis. What about biopsy? Yesterday I talked about our mapping biopsies where we use a brachytherapy grid and we go through it at 5-millimeter intervals. It's an intricate procedure and it takes a while. It takes an hour to an hour and a half to do these. And then what we do is we individualize each one of these specimens, we mark them so that, and we get a report back like this where the cancers are. We 3D reconstruct the prostate. As you can see here, this is where the cancers are. You get a nice view of it. Now you're in a situation where maybe we can ablate just the cancer and not the whole prostate. And we've shown, and I mentioned this yesterday too, in some 40 radical prostatectomies I've done on men that have had mapping biopsies and bad pathology, the correlation with this and the radical prostatectomy is 1-to-1. It's almost a perfect correlation. So this is where we were with breast cancer a while ago with the radical mastectomy, and now it's a lumpectomy. And I think that that's going to be the future in a lot of prostate cancers, even Gleason 8 cancers. And we're talking about focal therapy. We call it targeted focal therapy. People use ablating half the gland and 3/4 of the gland. We are good enough now to start targeting that. So what's the future? Here's what I think the future is. This is, and we're not the only people that have done something like this. We have an optical needle that uses a laser. You stick that in, and you get fluorescence of tissue, and you get different readings back. And I'll show you that in a minute. And then we can also take a biopsy from it. So it's a very simple system. And what we've done is we've done hundreds of these in prostates that have been removed. Just recently, we did it in vivo, and when we're doing radical prostatectomies, you can see here that we're doing the biopsies. We get those back, and then we can see how good this system is. As a matter of fact, what we've done is we use the laser light, we do a biopsy right there, we get this fluorescent spectra, we compare it to the biopsy to where it's positive, and it's a little bit scary. It's almost 90–95% sensitivity and specificity. And right now, this is being commercialized and being utilized and will be utilized in a large clinical trial. The importance here is that you set this thing up and you do a biopsy and a red light comes on, you can ablate rather than wait. And that's what the future is going to be, I believe. And you can ablate, and we're working on a whole bunch of things, electroporation, lasers, but things that are attached to this needle. So I think the future is going to be something like this, targeted therapy, and it's going to be more focused and a sort of a one-stop shopping. Thank you.
I think we have time after each talk for one or two questions rather than at the end when you have too many things around. Any question to Dr. Crawford?
One question. Hi, David. It's Howard Sandler.
Hi, Howard.
So HIFU's been around for a while and has a tough regulatory path to FDA approval in the U.S. Can you just speculate about the regulatory path to approval for additional ablative technologies in the management of localized prostate cancer in the U.S.?
Yeah, HIFU, as a matter of fact, they're going before the FDA in a couple of weeks, and I'm going to be actually meeting with them next week in Washington. A lot of these technologies, lasers, electroporation, AC current, are already approved for tissue ablation. Where HIFU and a couple other people got into trouble was went out and marketing them for prostates without an approval. So the device itself, these devices we're using are approved. Some of the 3D reconstruction is pretty standard. So I think, and actually, ablation can be not just electricity or anything. It can be radioactive seeds. It can be focused radiation. It can be Cyberknife. It can be lots of other things. I think the key is finding out where these cancers are, and then different ways to ablate them. We'll have a lot of different things to consider. We could drop a radioactive seed in when we see a positive, or a couple when we see a positive lesion. Thank you.
Thank you. Thank you, Carl.
The next prophecy will be given by Dr. Leonard Gomella from the US, please.
Indeed. Professor Hamdi had to apologize, but for some personal family reason could not join, and we wish him all the best. Please.
And the topic for the next talk is risk grouping will be modified.
Good morning. Again, thank you for the opportunity to review risk grouping. The role of prostate cancer risk grouping is really very core at how we treat prostate cancer. It helps us guide decision-making. It helps us predicting long-term recurrence, progression, and survival. It also helps us guide adjuvant and neoadjuvant therapy, and very importantly, it helps us guide clinical trial design today. So what I'd like to do in the first part of the talk is talk about where we've been, and in the last few minutes talk about where it looks like we'll be going in the next 10 years. So our current predictive risk options that we have in generally are things such as lookup tables, risk stratification analysis, other regression analysis, nomograms, and artificial neural networks. So if we go back historically, our first risk marker we actually had was PAP that goes back to the 1930s and the 1940s. And then as we moved into the 1980s and 1990s, using PSA as a risk stratifier became much more commonplace. So our traditional risk stratification really took a major turn in 1966 when tumor grading based on glandular differentiation and architecture on biopsies was used as a prognosticator. And we have many historical precedents for this, the WHO, Mayo, Mustafi classification. But it was really the pioneering work that everyone is well aware of by Dr. Gleason that turned this risk stratification into a real reproducible mechanism. Pretreatment PSA has been very important to us for risk stratification, and again, very pioneering work in the late 1990s by Drs. D'Amico and Parton allowed us to really start to use integrative formulas where we take histological data and then combine it with PSA to help us better define prostate risk groups. These are the Parton tables that I think were very, very commonly used in the 1990s and early into this century. This is the original D'Amico classification that I think really changed our approach to this area, where we looked at low, intermediate, and high risk. And this pioneering paper in 1998 in JAMA by Dr. D'Amico really showed that with risk stratification, looking at different treatment outcomes, you can actually get a good understanding over the years on how patients would do. At this point in time, we have various organizations that have accepted the standard and modifications of the low, intermediate, and high risk stratification. And in fact, we now have, because of the work of Jonathan Epstein and others for active surveillance, even a very low risk classification that is used commonly by groups such as the NCCN. Nomograms, again, still use these. These are used in some of our clinic settings to predict risk. Adaptive neural networks, David Crawford was very involved with the development of these, and I think these were the first harbingers of where we'll be going in the next 10 years. Artificial neural networks relied on computational analysis, decision-making, and this is something that we're going to see as we finish up, really is going to be the future in 10 years. Personalized healthcare initiative, the United States Department of Health and Human Services is really focusing on gene-based outcomes. And clearly, genomic testing is becoming mainstream in cancer care, so we've gone from PAP to PSA to histological. Now we're drilling down on the genomics and the genetics of prostate cancer for risk classification. The genomic applications are going to be used for risk and screening, but they're also going to be used, as they are today, for pharmacogenomics, deciding which drugs are going to work in which patients, and also, as seen here at the bottom, decision-making. We are now in an explosive technology phase, looking at genomics, epigenomics, transcriptomes, proteomes, and metabolomes, and a whole lot of other circulating tumor cell analysis. And it's almost becoming too much for us to really analyze on a regular basis. So I think what's going to be happening in the next 10 years is that computational biology and bioinformatics are going to be taking over. I think simple tables and simple one-off blood tests are no longer going to be useful. We now have 4 approved diagnostic genomic tests in the United States, all of them that look at different genetic markers, epigenetic markers, or markers of cell cycle progression. Again, individually, these may be marketed, but perhaps in the future we'll be combining all of these together. David Crawford showed you this diagram that he and Dr. Shore put together, looking at many different factors that go into decision-making in prostate cancer. This is a heat map looking just at one patient's specific androgen regulation pathway, again, presenting you with a lot of data. When you start to put this all together in the next 10 years, it's going to be overwhelming to all of us. This is just an example of looking at the multiple different factors that may be available to us for risk stratification in the next 10 years. And I think that's why we're going to need a computer to do this. I think that we're going to have an app for many of these laboratory tests, be they histologic, genomic, metabolomic, proteomic, and other analysis. So I know very confident that the explosion in technology, risk grouping will be modified. We're going to have numerous new biomarkers. We're going to have advances in technologies that are going to allow us to do more and more analysis on less and less pieces of tissue. We're now able to do genomic analysis on single circulating CTCs. However, with all these tests that are coming down the pike, there's only really few that are going to survive, either because of utility or because of cost. And I think it's unlikely, as opposed to our just PSA or just Gleason score, that it's unlikely that one marker is going to suffice in the future for risk stratification. And clearly, bioinformatics and computational biology are going to largely replace our clinical intuition. So I thank you very much for your attention and the opportunity to be here today.
Thank you very much. Question to Dr. Gomella, please.
I have a question.
Yes.
How common is today to use genomic markers in the United States today in the daily practice?
I will tell you that it is a growing option. Patients are actually asking for it. Our main challenge that we have in the United States today is, I think, as clinicians, we do not fully appreciate what genomic markers can and cannot do. The patients are now driven to ask for a lot of this. The New York Times had a very big article about a year ago that reviewed all of the genomic testing. Our big challenge, other than our inability to really understand how do we use these clinically, is our insurance companies reimbursing for many of these tests. And that's a frustration.
Thank you.
Thank you.
Thank you. So the next talk about the future will be given by Dr. Joel Nelson from Pittsburgh about PSA-based screening. By what will it be replaced as an alternative strategy? And we just heard that that's definitely not enough to have PSA. As we know, PCA3 is already a thing of the past. So we are eager to listen to you, John.
Well, thank you. I would encourage you not to be too eager. Many of the things I'm going to say have been said in the last couple of days and even in this session, but I think looking at them perhaps from a slightly different perspective would be useful. So I was asked to comment on whether PSA-based screening will be replaced by alternative strategies. And I think we should first think about what would be an ideal biomarker. So you want an ideal biomarker to be 100% sensitive. That is, that it could detect all cases of some disease. And you want that also to be 100% specific, and that is, it would detect all those that are free of a disease. Unfortunately, with prostate cancer, this actually is probably a bad thing for us to develop, because we certainly don't want to detect more cancers than we currently detect. And 100% specificity is going to be actually quite difficult, because about 25% of people we consider to be normal in fact harbor prostate cancer that in fact doesn't need to be diagnosed. So we need to think a little bit about what ideal biomarker means as it relates specifically to prostate cancer. So let me give you an example of the ideal biomarker for prostate cancer applied in this setting to screening. And you want to detect only those requiring treatment. And this is shown us vividly if you look at the data from Dan Lin, where he looked at a very large number of patients in a database in the United States. And if you were a young man, 35 to 44, and were diagnosed with Gleason 8 through 10, it was a significantly more lethal disease for you than it would be if you were any bit older. So if we had a test that we could have applied to these patients, perhaps in their 20 or 25 years old, and spare them from this fate. So successful alternative strategy requirements for biomarkers, obviously we want to have detecting the disease that requires detection, so-called smart sensitivity, which rarely would miss lethal disease. And we want to exclude those without disease, so we want really tight specificities. That is, we want a test that's going to have a high negative predictive value. The test, if it's going to be used in a screening setting, needs to be easy. I'm of the bias that having not to put a needle into a person's arm is probably the best, since we all make urine throughout the day. That would be a wonderful place to look for a new biomarker. There is a certain beauty, though, to serum and plasma. And I would say, as it exists today, unlike I think what the future for imaging is for treatment and monitoring a response to treatment, the technology simply doesn't exist today that it's feasible at a population-based level to do imaging. And obviously, you'd like this test to be cheap. So let me tell you, and this is very similar to what you just heard from Dr. Crawford, PSA is really going to be tough to beat. There is a high negative predictive value. So in the Swedish series that was reported, sorry, it's not showing up very well here, but it's showing up well there. The Swedish series that was reported by Vickers, 75% of a population-based group had PSAs less than 2. So this is, in fact, a test that will exclude the majority of the population from the presence of disease, and that's going to be hard for us to get better than. So improving prostate cancer screening, one of the things we can do is to take advantage of what we know about the natural history of progression of prostate cancer. And the group from the Rotterdam looked at their part of the ERSPC and came with a risk a tool that looked at the patient's age, what their PSA level was, what their exam was like, family history, their volume, and then what their previous prostate biopsy class was, and that would give them a score or a likelihood 4 years later of having either low risk or high risk prostate cancer. And if you had a very low % risk at 4 years, you really didn't need to be retested, or at most tested 8 years later. If you were at the high risk group, you needed immediate retesting. And this segregated their population quite well. So very few of the low risk patients actually had lethal disease. 0.3% would have high risk disease later. We've heard a little bit about the 4K score, and these are slides that I stole off the internet from Dan Lynn's presentation at the AUA late breaking. The 4K score takes advantage of total PSA, free PSA, HK2, and intact PSA, and then adds the same factors I just described from the Rotterdam study to come up with this so-called score. And then depending on the score, you can tell the patient what's the likelihood if I did a biopsy that you in fact would have cancer. And they reported at the AUA a study that was done in the United States that looked at using the 4K score with a 9% cutoff, and this would exclude 42, almost 43% of the biopsies, and only lost a little bit, about 2% of the high-grade diseases. So this, I think, is a potentially useful test. The PCA3 gene, which I had the fortune of being at Hopkins when Murray Bussmacher was the one to first describe this so-called DD3, is a non-coding RNA that we know now is expressed at very high levels in prostate cancer tissues, as you can see here on the right-hand side, relative to benign prostate cancer. And by simply massaging the prostate and collecting cells that are shed, you look at the ratio of PSA mRNA to PC3 mRNA. In my opinion, the best thing about the PCA3 test is that it has a very high negative predictive value. So if you have a low PCA3 test, your likelihood of having cancer is also very low. We know that PSA has been spun many different ways, and it takes advantage of the various components, complex and free PSA. But one of the elements that's sort of risen to the top is this idea of 2- pro PSA. So when PSA is cleaved, it can go a variety of paths to have the enzymatically active PSA, but 2- pro PSA is kind of a dead end. So once you get to that particular protein, it cannot be further processed. And this appears to accumulate in prostate cancer tissue, as shown here by the folks at Hopkins, that it correlates, in fact, with Gleason scoring. So this 2- pro PSA has been applied in the so-called Prostate Health Index, and the FDA recognized that this, in fact, if used, would reduce the need to do prostate biopsies, although, frankly, it was a very modest reduction, and this was the basis of the approval. In the United States, there is not a code yet that exists for this, and so getting reimbursed has limited the ability for the PHI test to be used widely. Well, we heard from Lenny about the future as it relates to genetics and genomics. I think that we're just at the cusp of beginning to understand what are things that we're born with that increase our risk. And so this was one of the early publications that looked at a particular genotype at 17p12, where if you carried this at birth, you had a significantly higher chance in, this is now in the American population, of having higher Gleason score and higher T-stage when you were eventually diagnosed with prostate cancer, as opposed to if you didn't have this particular genotype. Our lab has been looking at the molecular alterations in terms of amplifications, deletions, so-called copy number variants, in patients who had prostate cancer that didn't recur or recurred in a slow fashion or occurred in a rapid fashion. And you can see the amount of instability here, the amplifications and deletions shown there in the green and the red, seem to correlate in the primary tumor with the eventual outcome of the cancer. But very interestingly, when we look at the peripheral blood of men who have prostate cancer, we in fact find alterations and deletions in what we would believe to be normal DNA. And there's probably between 2 and 5% of our DNA has either amplifications or deletions that separate us from the person next to us in the chair there. And if we can begin to understand these in a meaningful way as it relates to disease status, this in fact could be the future. And so we're in the process of actively looking into this. So I wanted to take the last 2 minutes, and if you'll indulge me, on something that's only been presented once, and this will be the second presentation, and these data have just been accepted for publication. So to build on our observations of looking at DNA alterations in prostate cancer, we actually did a pretty thorough exam of several tumors. We did whole genome sequencing with 33x coverage, and then did RNA-seq at a very high level of coverage, so very deep sequencing on patients who had primary prostate cancers, their normal adjacent tissues. And then in Pittsburgh, we have lots of people who are dying of other causes who are donating their organs for transplantation, and we can harvest their normal prostates and use them as a good control. And so what was found when we did this, and this is mostly based on the very deep RNA-seq, that if you look in these tissues, we found 76 fusion events. 13 of these were confirmed by whole genome sequencing. We then eliminated any fusion events that occurred in normal prostate. And yes, fusion events occur in normal prostate. When you do RNA-seq at such a deep level, you begin to find these aberrant transcripts. We also eliminated any reads that were close, so if it looked like it could just be a deletion event, and everything had to be read in the cis direction, so there had to be some alteration in the actual DNA. So based on this, we came up with 28 prostate cancer-specific fusions. PCR products were generated across the fusion breakpoints and sequenced, and of this, we got down to a final group of 8 prostate cancer fusions that were then validated by FISH and confirmed. So we wanted to ask the question, were these at all useful as we looked at recurrence of prostate cancer? And so we took advantage of the tumor banks that exist at the University of Pittsburgh, Jim Brooks's tumor bank at Stanford, and Dave Gerard's tumor bank at Wisconsin. And we defined recurrence in the standard fashion, PSA over 2 within 5 years of radical prostatectomy, and then we further segregated these based on the PSA kinetics of that recurrence, i.e. is it a lethal recurrence, quick PSA doubling time versus one that's not lethal, slow PSA doubling time. And then another population defined as having no evidence of PSA with a minimum of 5 years of follow-up. And so on the far right-hand side are the fusions that we'd identified, and you can see that in the University of Pittsburgh cohort, if you had the fusion, you had a 52% chance, or if you had recurrence, you had a 52% chance of carrying at least one of these fusions, whereas if you did not have a recurrence, you only had a 7% chance of having one of these fusions. We then went to the Stanford and Wisconsin cohorts and found very similar results with the specificity of fusion of being over 90%. And you can see if you apply these to a Kaplan-Meier analysis that having a fusion in your primary tumor is not a good thing. Well, that's fine, but how does this add to what we know clinically? And this has been one of the problems, as you know, with biomarkers, is that you actually have to test them against available clinical information. We used ostensibly one of the better tests, which is the prostate cancer nomogram that was developed at Memorial Sloan Kettering, and asked of our patient population that we studied, if you use the nomogram, what's the chance that you'll have, or greater than a 10% chance that you'll have a PSA-free survival for 5 years? And you can see in our cohorts the accuracy, sensitivity, and specificity. But if we added fusion status to that same clinical variable, you can see now that the accuracy of this test goes up in every single one of the cohorts that we looked at. So what do I think the future of screening for prostate cancer will be? Well, first, as I said earlier, PSA or its various components defined by PHI or a 4K score are really going to be difficult to replace, mostly because they're very good at telling us who doesn't have the disease. Germline changes, I think, have the hope of allowing us to select a population that's the most at risk and need to be screened more intensively. And I think that DNA-based as opposed to expression-based, and most of the other genomic tests that exist today are mostly RNA-based, but I think the DNA-based assays are most promising because the alterations appear to be much more stable, and this could be in copy number variants, fusions, or gene methylation. So I thank you for your attention, and I'm happy to answer any questions.
One question. Since, according to what you said, we're not going to see the ideal marker in the next 10 years, so what is the level of accuracy that as a physician and as a patient, someone will accept as an optimal marker or something that is close to be optimal? How low it has to be, how high the negative predictive value should be in order to be used safely?
Yeah, I think it's a wonderful question. It has a lot to do with how you frame the question for your patients, but I would say, in general, anything that has a negative predictive value over 90% or a 10% positive score is very useful. So if you have a negative predictive value over 90%, I think clinically that's very useful for us, because you can tell the patient there's 1 chance in 10 you have the disease, right? That's pretty good odds. I think anything above that, people get pretty nervous. In the 4K score, they used a 9% as the cutoff, sort of in the same range. It does mean, unfortunately, that lots of people then still will have unnecessary biopsies. And so that's the way to sort of phrase the question to them. How do you want to avoid an unnecessary biopsy?
Please.
Tim Oliver, London. You didn't really go into PSA as a marker of inflammation in prostate and as an epidemiologically causative factor for prostate, because it's as efficient as marking inflammation, and inflammation, proliferative inflammatory atrophy, the genes that the Hopkins group have found are clearly pointing in that direction, and it may well be that we should be looking more at actually using PSA to screen out people who've got increased inflammation at a younger age, and will actually then improve the specificity of your actual screening process.
So I'm very aware of the Hopkins PIA inflammation story. It desperately needs to be experimentally validated, and to my knowledge, that's never occurred. But to screen men who have elevated levels of PSA based on inflammation is, I think, an interesting strategy. Unfortunately, it's going to mean you're going to subject those men who, in fact, don't have cancer to invasive procedures like biopsies.
Well, unless you find simple treatments like vitamin D and aspirin, which is what I'm proposing in the poster 7, that actually might reverse this by simple interventions.
Okay, but let's finish. Quickly, please. David?
So, great work. You know, there are 2 other tests that are out there that look at prostates, the Prolaris and Decipher. And one is survival, one's recurrence. How do you think yours fits with those? There's been a lot of work done with those already.
So we have not taken our data and applied Prolaris or Decipher to these same patients, so I can't speak to that. But I think it's important to recognize that if you carried one of these fusions, you have about a 90% chance that you're going to have a recurrence. This is much, much better than either one of those 2 tests.
Laurie?
MRI is starting to emerge as an alternative to biopsy. I just wonder if you can comment on the future of that approach. It's a biomarker in a sense.
Yeah, so to me, the most interesting data I've seen so far at this meeting is the stuff that Rob presented yesterday that shows about a 50% sensitivity of MRI and the large number of tumors that are missed. So I certainly don't see MRI having any future as a screening tool in the population at large. Having said that, I think that imaging is clearly the future of our field as it relates to assessing treatment response. And if we have a way of imaging the prostate that currently doesn't exist, but I hope it would, then the days of radical prostatectomy will go away. We'll be able to simply ablate tumors.
Last question, please.
So, as a radiologist, concerning the MRI, the sequences are becoming shorter and we are changing, things are changing. So since we are thinking about the future, MRI will be shorter, cheaper, and I think more accurate. And since we are guessing that maybe there won't be some other very accurate other thing, I would not discard MRI for screening.
Well, I appreciate your enthusiasm for the technology, and I believe that we should continue to work on it. Having a completely normal MRI, and that remains to be defined, appears to be pretty useful as a way of saying somebody doesn't have prostate cancer. But it's got to do better than having a PSA less than 2, because that excludes immediately 75% of the population. And it's a simple blood test that costs $13 in the US.
Thank you.
Thank you very much. And the next talk will be given by Dr. David Margel, and he's going to tell us his vision about declining mortality for prostate cancer. Tell us why.
Thank you very much for the opportunity to present here today. I was given the task of predicting whether we will see a significant decline in prostate cancer mortality in 10 years from now. I will go over some things that I believe that will need to be addressed if indeed we see a decline. The first is a new screening paradigm. I'll talk about multimodal treatment for high-risk localized prostate cancer. I'll talk about the management of metastatic hormone-naive cancer, the management of castrate-resistant prostate cancer, and prevention. Now, if you look at the continuum of the disease, prevention should probably be the first thing I talk about. But I believe that if we really want to affect mortality, maybe this is the most important thing we need to think about, and therefore I decided to end my discussion with that. So before we look at the future, let's see what's happening now. At present, we're pretty good. This is SEER data from 2010, and if you have prostate cancer in 2010, your chances of dying is less than 0.2%. That's pretty amazing. If you look at 10-year survival rates, they're over 90%. And if you break it down to localized and regional prostate cancer, it's almost 100% in 5 years. Metastatic disease, however, is only 30%, and if you look at 2014 data, it approaches 50%. So getting better than this is going to be very hard. But what will happen in the near future? We're all aware of the U.S. Preventive Task Force Grade D recommendation against PSA-based screening. Will we go back in time? Will we see a disease that is more advanced and non-curable? This is a study published by Rob Avosali's group at the Case Western showing that even this shortly after the recommendation, PSA-based screening in the U.S. has gone down, and mainly by urologists, not by family physicians. So will lower rates of screening actually increase mortality and not decrease it? What we need to adopt, and I think that's what we heard about before, is risk-stratified screening. We need to target the screening at the population at high risk of lethal prostate cancer. So we may target race, Africans or Caribbeans. We may target specific mutation carriers like BRCA and Lynch. Or alternatively, a study by Vickers demonstrated that with a single PSA test done between the age of 45 to 50, we can detect over 60% of those who are going to die from prostate cancer. So a simple PSA test may cause us to risk stratify patients and therefore follow those who are more likely to have lethal disease and maybe discard the rest from our follow-up. Now, NCCN guidelines that were recently published adopted this in their guidelines, and they suggest that to do a one-time PSA between the age of 45 to 49, and if it's below 1, then maybe repeat the test at age 50, but leave the patient basically alone. But if it's above 1, which is above the 75th percentile for that age group, that's a dangerous patient. That's a patient that may die from prostate cancer. And these are the patients we need to focus on. Another important part of this equation is when to stop screening. Screening should probably stop at the age of 70, definitely stop at the age of 75. Because these patients who are screen-detected prostate cancer at the age of 75 do not benefit on longevity. We all heard of novel biomarkers, but as the prior lecturer already said, it's going to be very hard to replace PSA. PSA is pretty good. It's a very effective primary screening test. And we should use it, and I believe that in 10 years we'll still be using it. Now, will multimodal treatment for high-risk localized prostate cancer affect mortality? When you look at clinicaltrials.gov, there are over 19 studies that are open that are trying to do neoadjuvant chemotherapy, surgery, and radiation, combinations with new androgen deprivation agents, all these to try to decrease mortality in high-risk patients. But if you look closely, this is the results of a large series of over 3,000 patients with high-risk prostate cancer recently published at the European Urology. Even patients with high-risk prostate cancer, the 10-year prostate cancer-specific mortality is 10%. Most of them die of other causes. So even if we really try and lower the mortality rate of prostate cancer by combination therapy by 50%, the absolute risk reduction will be only 5% among this small group. Therefore, I believe we will get better in treating localized high-risk prostate cancer, but will that affect overall mortality from prostate cancer in 10 years? Probably not. Metastatic hormone naive. So this is the study that was presented at ASCO this year, maybe the most important finding in prostate cancer this year. A randomized study randomizing 790 men with metastatic hormone naive cancer to androgen deprivation therapy versus androgen deprivation therapy plus 6 cycles of docetaxel. And they stratified a priori between high and low volume metastatic disease. They defined high as those with primary 4 or more bone metastasis or visceral metastasis, and they demonstrated a very large median overall survival benefit, on average almost over a year, and among those who had high volume disease, almost a year and a half. That is an amazing achievement in cancer, and this has already changed practice in many places after the press release, and will definitely change practice over the years, and more patients with metastatic hormone-naive cancer will receive immediate docetaxel with ADT. Now, castrate-resistant prostate cancer. If we were here in 2010 World Cup, Soccer World Cup, not many agents have been approved by the FDA in 2010, only docetaxel and maybe Zomera. Moving forward to 2014, there are so many new drugs we have in our armamentarium to tackle this castrate-resistant prostate cancer. We have new hormonal therapies with arbireterone and enzalutamide. We have immunotherapy. We have bone-targeted agents, and we have chemotherapy. But many questions still remain. We still don't know who should receive what. Should we start with arbireterone? Should we start with enzalutamide? We don't know, is there an added benefit? So if you start on arbireterone, a patient fails, and he receives enzalutamide, does that increase his life? We don't know. Should we use combos? We still don't know. So many questions still remain, and I believe in the 10 years from now, we'll get several answers for these important questions. But we are still delaying. We are not curing. And the only way we may be able to cure prostate cancer is prevent it. And as Benjamin Franklin said, an ounce of prevention is worth a pound of cure. Prevention 2014. When I talk to a patient and he asks me, what do I do to avoid prostate cancer? I basically tell him, I have nothing for you. There have been numerous studies. There have been studies about micronutrients and vitamins, and we all remember SELECT, and other studies which were negative. There was chemoprevention, 5-ARIs, despite 2 large randomized studies showing that 5-ARIs may prevent prostate cancer, the FDA disapproved, maybe because of the risk of high-risk prostate cancer. Metformin, I've studied metformin chemoprevention, still not yet there. Statins may be used in the future. Lifestyle modifications like physical activity have also been studied, but still nothing is proven. What I do tell a patient is, if you have a healthy heart, you'll have a healthy prostate. And that's about what I know now.
That's true.
What I do believe is that large-scale primary prevention studies are not going to happen. The flavor for a large-scale primary prevention study for prostate cancer after the SELECT is not there. You look at the stakeholders and they're saying, no, we're not going to invest our money in this. So what do? I think the future of prevention in prostate cancer lies in 2 ways. First of all, active surveillance. Preventing progression in active surveillance is one of the future ways we can learn about prevention. And why is that? We have many outcomes in a short time. We don't need to accrue thousands or millions of patients to do a preventive study. The REDEEM had only 300 patients and was positive. The MASS study, which is metformin in active surveillance, is aiming to accrue 400, and their power calculation, if it is enough to prove their point, if metformin actually works. So I believe this is one of the areas where we're going to move forward in prevention in the future. The other strategy we might use is personalized prevention. We know a lot about, and everybody talked about genetics this couple of days. We should harvest the knowledge we know from Oncotype, from Polaris, from ConfirmMDx looking at epigenetics, and try to target specific pathways to a specific person, and therefore come up with a personalized prevention strategy that may cause stakeholders to give us the money to actually do these studies. So in 10 years from now, we'll adopt a new screening paradigm, possibly with new biomarkers, but even PSA can be used differently. We will manage high-risk localized and metastatic disease better, and I hope we'll have personalized prevention programs. Thank you very much.
Thank you very much. We cannot take questions now.
Yes, well, let's please invite and listen to Dr. Michael Zelefsky, a world-known radiation oncologist, about the future of other approaches. Please.
Thank you very much. It's wonderful to speak about something where you can just simply speculate, and that's obviously the point of this very exciting session. So I will be talking about how Cyberknife, but Cyberknife is just a brand. It's really what it is ultra hypofractionated short course radiotherapy, which I believe will become an alternative to standard approaches for clinically localized disease. The emergence of high-dose short-course radiotherapy is really becoming more and more popular because we have the tools right now to implement this. We have highly targeted and accurate treatment delivery machines that make it feasible and really safe to deliver the ultra-hypofractionated treatments. These are external beam radiotherapy treatments delivered in classically 5 sessions. Real-time image guidance, we have those tools as well. Even intrafraction during the actual delivery of the radiation with kind of GPS guidance, we can see where the prostate is moving and make the appropriate adjustments to enhance our accuracy. This allows us to deliver the treatment, high-dose treatment, with very tight margins, which allows us to then exclude more of the normal surrounding tissues. Ongoing trials are happening as we speak, paving the way for broad acceptance of this form of treatment. And I believe in 10 years we'll have already the answers to these questions, and I believe these will ultimately replace conventional 9 to 10 weeks of external radiation. Of course, it's popular, it's convenient, 5 treatments over 1.5 weeks, and while Dr. Sandler said in another session, it's just a matter of minutes or hours, there's no question that the popularity of these treatments are very powerful. 5 sessions just coming in for eventually maybe just in a week and getting all of your treatments done. It's accurate, it's probably less toxic than maybe even standard external forms of treatment, but time will tell with the studies, and possibly associated with greater tumor control related to the higher doses of radiation delivered in shorter periods of time, which theoretically should allow us to see greater increase in intratumoral biological damage of the cells. Here are color wash distributions for a 9-field image-guided hypofractionated regimen, and as you can see, the radiation is delivered in a highly conformal way with the exclusion of normal tissues, and this should allow in the future less late toxicities as we so far see in preliminary studies. Here's a compilation of a number of series in the literature, and the take-home message is that we don't have thousands of patients that have been treated this way, but the early published results are encouraging. These are with 5-fraction or ultra-hypofractionated treatments. The typical doses that are used are 7.25 gray times 5, which end up being about 35 or 36 gray in these 5 fractions. The follow-up is generally about 2 to 5 years, and so far, preliminarily, PSA control is excellent, but it's still premature, and we need to await for the longer results. I believe in 10 years we'll still see excellent results comparable to external beam conventional approaches and perhaps surpassing it. Toxicity outcomes also appear to be so far excellent, but as Dr. Sandler had mentioned in another session, and correctly so, we need to in particular wait for urinary toxicities because these could manifest a little bit later. And so far, once again, related to the tight delivery, highly conformal distribution of the radiation doses, we are seeing that the significant toxicity levels, that is grade 3, still remain low at these studies which are generally at the 3 to 5 year time points. And there are ongoing phase 3 trials looking at different regimens of hypofractionated, ultra-hypofractionated treatment to an extent. 78 gray in 78 gray conventional, that's fractionated treatments, versus 42.7 using 6.1 gray per fraction. Conventional fractionated treatments, as you see here, versus 38 gray using 7.6 gray per fraction. And in this PACE trial, actually testing whether we will see a replacement even of other forms of therapy, such as radical prostatectomy or IMRT versus SBRT in the surgical and non-surgical cohorts respectively. Maybe answers to these questions we're talking about now will ultimately be realized. And I think even for high-risk prostate cancer, appropriately, this is being studied in prospective trials where we are looking at these patients to incorporate with hypofractionated regimens the treatments of the lymph nodes as well. In this study here, the Saturn study, looking at 8 gray times 5 and incorporating the lymph nodes as well. And as you notice here, even with all of these trials, it's not yet well established what is the optimal dose per fraction. Is it 7.5 gray that are used at each session? Is it 8 gray? Is it more fractions or less fractions? And that certainly needs to be evaluated. A study that we're about to embark upon is utilizing some novel anti-androgens such as abiraterone in conjunction with standard hormonal therapy and ultra hypofractionated regimens, and we're going to be seeing more and more of this. We are going to be in 10 years replacing these long courses of therapy with short course therapy and incorporating systemic therapies along with it. And we are finishing up and moving well on an ongoing phase 1 dose escalation study where we really don't know what that optimal dose per fraction is. And here we have looked at, in a sequential way, 6.5 grade times 5, 7, 7.5, and 8. And actually, I just got an email today that we just finished the accrual of this 4th dose arm. Well, what's interesting about this prospective evaluation is that we are biopsying all of these patients at 2 years to better understand what the local tumor control outcome is. And so I would say that, in conclusion, the optimal dose and fractionation regimen has not yet been established, but I believe in the next 10 years we'll have a much better sense of it. The preliminary results indicate excellent biochemical control and tolerance, especially when using tight margins, intrafraction, sophisticated image-guided tracking, but longer follow-up is needed. And I believe in 5 and especially in 10 years from now, this approach will replace the protracted daily sessions of external beam radiation because the patients will be demanding it. And even if it's ultimately the same as conventional fractionated regimen, certainly the convenience factor will surpass. It's going to be less invasive than surgery. It's going to be compared to brachytherapy, not requiring any anesthesia. And compared to conventional external radiation, it will not be a burden for the patients we treat. Thank you for your attention.
Thank you very much for the speaker and for the audience, and we take the lunch break.